Psychiatric presentation of physical disease. Epidemiology. Psychiatric symptoms are common in general medical conditions. For example, on general medical wards, 15 to 25% of patients experience delirium. 30 to 50% of patients with epilepsy have a psychiatric difficulty at some time. Clinical presentation. When medical conditions have psychiatric symptoms as part of their presentation, it is necessary to decide whether the psychiatric symptoms are a result of the medical illness, part of a separate mental disorder, a psychological reaction to having an illness. NB. Symptoms should be elicited that identify serious mental illness or distress, and which need to be addressed urgently. These symptoms include hopelessness, thoughts of suicide, guilt, loss of interest, severe insomnia, psychosis. Common mental disorders that may be the result of an underlying medical condition or medication are as follows: delirium, dementia, amnesia, mood disorders, anxiety disorders, sleep disorder, sexual dysfunction. Medical conditions that commonly present with symptoms and signs of mental disorder include epilepsy, degenerative disorders, e.g. Parkinson's, Huntington's and Wilson's diseases, brain tumors, head trauma, demyelinating disorders, infectious disease, e.g. syphilis, encephalitis, meningitis, Creutzfeldt-Jakob disease and HIV, AIDS, autoimmune disorders, e.g. systemic lupus erythematosus, endocrine disorders, e.g. thyroid, pituitary and adrenal disease, metabolic disorders, e.g. hepatic, uremic, hypoglycemic encephalopathies and porphyria, nutritional disorders, e.g. thiamine and niacin deficiencies, toxins, e.g. organophosphates and heavy metals. NB. Other comorbid problems that may complicate the picture: alcohol and drug abuse, personality disorders, factitious disorders and malingering. Treatment. A general principle is to address medical problems as far as possible before attempting to treat any psychiatric symptoms or suspected mental disorders, because these may resolve. However, circumstances may be such that recovery from the medical condition is dependent on the person's mental health and his or her ability to cooperate, in which case the psychiatric symptoms should be treated early. For example, a person with diabetes may find that motivation to remain compliant with treatment is poor because of concurrent depression. NB. Psychiatric treatments in physical illness. Treatments are the same as would be used in patients who do not have concurrent physical illness, but be aware of drug interactions and adverse effects, e.g. anticholinergic effects of tricyclic antidepressants. Treatment strategies to help alleviate psychiatric symptoms include the following. Use an empathic, reassuring approach. Ensure the patient's physical needs are met, e.g. hydration and nutrition. Provide information about illness, investigations, treatments, and their likely effects to help allay any fears and anxieties. The nursing environment should be well lit, quiet and tranquil. Invite the patient's family or other people who are familiar to visit. Hypnotics and anxiolytics should only be used if the patient is not responding to the above treatment strategies. If there is concern that the patient is severely depressed or psychotic, a psychiatric opinion should be sought immediately. Furthermore, a psychiatric assessment may be helpful in identifying the psychological processes that are affecting recovery and compliance. Psychological reactions to physical illness, adjustment disorders. Etiology and Psychopathology. When considering the possibility of a psychiatric disorder in a physically ill person, think of the possible interactions between mind, body, and behavior. Possible interactions between the mind and physical illness. Coincidental, a person with schizophrenia contracts pneumonia. Causal, physical illness causing psychiatric disorder, e.g. hypothyroidism causing depression. Reactive, anxiety and depression are the commonest reactions to threatening or progressive illness. Iatrogenic, treatment of physical illness causes a psychiatric disorder, e.g. L-dopa causing delirium. Reciprocal, failure to mobilize after a stroke causing or caused by depression. Compliance, poor compliance, e.g. in the depressed diabetic or in the patient with memory impairment. Somatization, psychiatric illness presents as a physical one. Denial, a psychological defense mechanism by which frightening news, e.g. a diagnosis of cancer, is excluded from conscious awareness and the patient behaves as if unaware of the distressing facts. The commonest reactions to physical illness and disability are adjustment disorders. These are generally seen in primary care, but 5 to 20% of psychiatric outpatients may present with this clinical picture. The stressor is usually much less intense and severe than in cases of post-traumatic stress disorder. The onset should be within 1 month or so of the stressful event. Predisposing factors include personality disorder or immature personality or a succession of major life events. Epidemiology. Males and females are equally affected. Clinical presentation. Usually presentation is with severe subjective distress and emotional disturbance. This is based on the clinician's own subjective judgment. Impairment of social functioning and performance. Onset is within 1 month of a significant life change, leading to continued unpleasant circumstances. Symptoms include depressed mood, tearfulness and/or hopelessness, nervousness, anxiety, disproportionate worrying, inability to cope or plan ahead, disability in performance of daily routine. The symptoms are not sufficiently severe to justify a more specific diagnosis such as major depression. The usual duration is a maximum of 6 months. Symptoms can last longer in a chronic disabling medical condition. Diagnosing depression in physical illness. Approximately 30% of patients with cancer develop depression, generalized anxiety disorder or an adjustment disorder within the first 2 years of diagnosis, but only a small proportion of this morbidity is recognized and treated. NB. Depression in physical illness. Be aware of the following. Dismissing depression as an understandable reaction to severe illness. Biological symptoms are unreliable, therefore use the Hospital Anxiety and Depression (HAD) scale. Depressive cognitions, e.g. I deserve to be ill or I am not worth treating. Also a loss of interest in other people. Suicidal ideas. Tearfulness, especially in men. Indecisiveness. Any past history of depression. The diagnosis of depression in patients with physical illness can be complicated by the presence of fatigue, loss of appetite and sex drive, insomnia. These symptoms can also be the typical biological symptoms of depression. Therefore, it is helpful to use the HAD scale that excludes somatic symptoms and concentrates on the psychological symptoms of depression and anxiety. This self-rating scale has only 14 items and is easy to complete and to score. It was designed specifically for use in non-psychiatric hospital departments. A score of 11 or more on either the anxiety or the depression subscale indicates caseness. The range on each subscale is 0 to 21. Treatment. Encourage discussion and ventilation of feelings to help overcome denial and avoidance. Teach a problem-solving technique. Problem-solving technique. Problem-solving is a straightforward counseling technique with the following components. Listing the problems. Selecting one specific problem to focus on. Listing alternative courses of action. Evaluating each action plan. Selecting and implementing the most promising course of action. Evaluating results of the trial. Repeating the process until positive results are obtained. This technique is applied collaboratively with the patient, who takes responsibility for the process, thereby enhancing their sense of autonomy and control. Complications. Decreased compliance with medical treatment. Increased length of hospital stay. Impaired performance at work. Disruption of social relationships. Increased risk of suicide attempts and suicide.